All right, so welcome to my afternoon report.
Not the title.
Oh,
Not
yes,
the title.
the title actually is relevant, so I'm sure you'll see where this is going eventually. So I'm hoping for some audience participation. Otherwise, it's all going to go very badly. So please get involved. So this starts in clinic, which is a little bit different to other afternoon reports. Okay, so you're in outpatients. You've got a 59-year-old woman, and she comes to you and says, "My eyes are going yellow." A little bit more of the HPI. So this has been a subacute process. It's been the last week or two. She has no abdominal pain. When you ask about weight loss, she says that she's lost a little bit. She finds it hard to quantify, but maybe about 5 pounds over the last couple of months. She's not really been checking. She hasn't noticed any changes in the color of her stools or urine, but she's had a non-specific fatigue for the last 2 months. She just feels a bit listless, lack of energy. So what other questions would you like to ask?
Any past medical history?
Yes. Can I just, the past medical history I'll get to. Any other questions from the history of presenting complaints first?
Any itchiness?
Sorry?
Any itchiness?
Itchiness, no itchiness. Maria's question, intentional weight loss supplements over the counter. So she said the weight loss was unintentional. She's not taking any supplements and nothing over the counter.
Any changes in sleep-wake cycle?
No changes in her sleep-wake cycle. Kiran, so the question is any change in diet. She said that she was eating a bit less, just she didn't really have an appetite, but nothing beyond that.
Mantej, has she ever had this before? And has she ever had blood transfusions or surgeries before, which I guess you'll be coming to?
So she has not had any jaundice before. She had surgery actually a few months ago, which I was going to get to, but she had a total abdominal hysterectomy and a bilateral salpingo oophorectomy in March 2021 this year. So like 5-6 months ago, no previous transfusions.
Okay.
The questions are flooding in, so let me just try and get through them. So
Finn, I can read them out for you.
Okay.
Here. Hi.
Yeah.
All right. So any travel?
No travel for more than 2 years.
IV drug use, alcohol use.
So moderate alcohol use. She says maybe 1 glass of wine a day. No IV drug use.
Okay. Any night sweats?
Nope.
Polyuria, polydipsia.
Nope.
How about abdominal swelling?
No abdominal swelling that she's noticed.
Family, so family medical history, or any personal history of hepatitis?
No family history that she's aware of. She says she was adopted, so she doesn't really know, but nothing definite. And no personal history of hepatitis, no.
Okay, so that answers your question regarding the autoimmune disease in the family. And then I see here, has she used Tylenol recently?
No Tylenol. No, yeah, I'm sorry, I clicked something. Yeah, no Tylenol.
Chris is asking any diarrhea or blood in the stool. What are we thinking of, Chris?
Sorry?
Your question. I don't
know.
Mm-hmm.
No, I was just thinking if she had something that then led to these jaundice changes, like if she had, let's say, if she has an abscess, or if she had Crohn's disease and now she's developing PSC or primary biliary cirrhosis.
Interesting. What's the answer, Mantej? Does she have any diarrhea or blood in the stool?
No, and if you're also asking about maybe hepatitis A or E and the kind of the gastroenteritic prodrome before you get the jaundice and those illnesses, it's a good thought, but she didn't have anything like that.
Okay. Karina. Oh, she's asking more about the surgical history. Why did that
Yeah,
happen?
good question. So the history is a bit odd. So she said that she had some ovarian cysts that they did this operation for, and they actually turned out to be benign afterwards. Okay, if there's no further questions, so this slide, so yeah, just going over what we've already asked. Moderate alcohol, no new drugs, no bleeding, no tattoos, blood transfusions, or foreign travel. When you do a review of systems, so she was describing this continuous nausea that's associated with probably a loss of appetite. She does say that she's vomited maybe 2 to 3 times over the last 2 to 3 weeks, but no diarrhea, as we mentioned. She's had some arthralgias in her knees and hands, and really very non-specific intermittent headaches that she's not able to, characterize very much. So the rest of the medical history, so past medical history of hypercholesterolemia, osteoporosis. She had COVID-19 in December 2020, for which she was just managed in the community, didn't need admission. Takes no regular medications. There's no known liver disease or hemolytic disease in the family. The surgeries we talked about, so the THBSO in March for 2 ovarian cysts that ended up being benign. And the social history otherwise, so no recreational drugs. She was an ex-smoker of more than 15 pack years, but she quit about 10 plus years ago. And she's not been sexually active for more than 5 years. On examination, so she is clinically jaundiced, there's scleral icterus, but beyond that, there's no other major findings. There's no evidence of chronic liver disease, no evidence of bleeding, no petechiae, and that's about it. No asterixis. Neurologically, she's normal, interacting completely normally. So does anyone want to try a problem representation?
Can you put up the HPI again, just for like the time course of everything?
Yeah.
Sorry, and how old is she?
59, 59, yeah, middle-aged.
Okay, so I'm happy to do problem representation. So it's middle-aged lady presenting with subacute onset of jaundice, associated with some episodes of nausea and vomiting, who has few risk factors for acute viral hepatitis, and no stigmata consistent with chronic liver disease or cirrhosis.
Yeah, I think that's pretty great. Sort of expertly done, Karina. So I think this is one that Sonia suggested as well. So middle-aged woman, ex-smoker with a history of COVID-19 and recent THBSO, who is presenting with subacute painless jaundice, arthralgias, 5-pound weight loss and fatigue, without stigmata of chronic liver disease or evidence of acute liver failure on examination. So I think at this point, we were going to talk a little bit about jaundice.
Before we do, we might have missed a question in the chat. Noor was asking, which month is she presenting with jaundice? And Noor, why do you ask about the timing for this season?
Just to see the timeline of the presentation and compared to the last surgery and COVID vaccine.
Interesting.
I saw this patient in August, late August.
All right, well, thank you for that. All right, so bear with me. I'm gonna try. See if it works this time. Okay. So we're going to be talking a little bit more about jaundice, I guess. And
sorry, can I ask one question?
Absolutely, Kirtan, go ahead.
Are her like sugars under control when you saw her? Did she have like recent onset diabetes?
A buddy and endocrinologist about this.
I know it's so cliched, but just
Embarrassingly, I don't think we checked her blood sugar. This was in clinic, remember? So we didn't have
her
the
like
full.
A1Cs, as far as you know, were normal.
As far as I know, they were normal.
Okay.
Yeah.
Thank you.
Why?
That's a good question. Why?
So I was thinking of like the discoloration of skin with the arthralgias, and I was thinking if she's recently stopped menstruating, if her like hemochromatosis could be showing up. So I was thinking if there's like diabetes. It's a little far-fetched, but yeah.
It's a great thought. Great thought. We didn't have that excellent thought in clinic, unfortunately, so we didn't check those things. But as far as I know, the HbA1c was normal.
Thank you.
Yeah. And no changes in urine, David.
Thank you so much, guys. All right, so jaundice. Not the most intuitive name, but it does, I found that, come from the French jaundice. Please do not pardon my French. That actually means yellowing. So that's what we see, sclera, skin, mucosa. Sometimes we don't think we see it, but it's also related to the tone of our skin, and it can also be related to the ambient light, which is not the best sometimes in our hospital or any hospital. Now, obviously, we know that this is related to an elevation in bilirubin, right? Because it's probably better. Now, it will take a level of bilirubin that it's at least, I'm going to use this here now, it's at least greater than 2.5, maybe 3.5 milligrams per deciliter for us to see jaundice, right? Now, this pigment we also see in our bruises when they're getting better and they turn yellow. Our urine is yellow because of this, and even the color of our stool is related to that. So because the main culprit of this yellowness is bilirubin, I think it's important to know where it comes from. And this is where the joins will happen. Now, we have, oh, I could do a better job. All right, so when we have a red blood cell that's sort of nearing the end of its lifespan, which is about 120 days, this red blood cell might be eating up, phagocytized by our macrophages. Now, once that happens, what we see is that it splits the hemoglobin, it's right here, into two groups. We'll see the globin, which will later break down into amino acids, in a heme group, which we know is composed of iron and protoporphyrin. And this is what will become our unconjugated bilirubin. Now this, let me just move this aside, will ultimately be transported to the liver. And then it's in the liver that this will become a more soluble form of bilirubin, which is a conjugated bilirubin. Ultimately, this will drain. If I can kind of understand what that is, maybe. Ultimately, this will drain and it will be stored in our gallbladder. And when we eat something, then that's released into our duodenum, right? Now, we do use the term of direct and conjugated bilirubin sort of interchangeably, but that's only in the clinical practice. I found out that it's not the same and it's related to the proteins that it's linked to. Now, when we are thinking of conjugated bilirubin in the framework for jaundice, well, we need to subdivide this in, hopefully my text you can see from here, is what's happening, whether this is increased production or maybe a decreased clearance. All right. Let's split this like that. All right. Now, when we discussed an increased production, we have to think that pathology can probably be hepatic, which is usually what we see in hemolysis. Okay, I hope I didn't misspell that. Then intrahepatic. I'm just going to say intra. And usually intrahepatic is, intrinsic liver disease or post-hepatic. And then that's what we usually see with biliary obstruction, right? And then we're going to write here liver. Now, when we're thinking of pre-hepatic pathology, we can further subdivide this hemolysis process, obviously, in intravascular hemolysis. I'm just going to minimize your faces so I can see this better. Right. So let's say intravascular hemolysis and extravascular. All right. Now, when we're discussing intravascular hemolysis, it's a big umbrella of diseases under microangiopatic hemolytic anemia. So if you're thinking, thrombotic, thrombocytopenic purpura, HUS, in extravascular, I forgot to mention a more rare condition, NPH. All these conditions lead to intravascular hemolysis. Now, if we're thinking extravascular, we may think of, whether this is an RBC defect that's intrinsic, intrinsic or extrinsic. So some intrinsic RBC defects, and you can see I neglected the text because it's too complicated. So hopefully you understand my handwriting. So some intrinsic defects, come with hereditary conditions. So G6PD deficiency, sickle cell disease. What else can we think of? Other membrane defects, more rare conditions. All right, in extravascular hemolysis, we can think of many things. And I'm just rushing through this. I'm not going to ask you guys here because I know we have a little time and I want to get to Mantej's presentation. We can think of infections, autoimmune conditions, right? So autoimmune hemolytic anemia, even hypersplenism. Right, I'm just going to say here spleen. All right. Now, once we move towards, those conditions that decrease the clearance of, bilirubin and lead to jaundice, we have to think of it, whether it's coming from the liver or whether it's coming, from a biliary obstruction. Now, there are many categories when it comes to intra or intrinsic liver disease. It's mostly you have to think of things that will affect either the transport or the conjugation, and things that will lead to intrahepatic cholestasis. Right? So when we're thinking of transport and conjugation, there's something that's actually, a very benign abnormality. It's called Gilbert's disease. It's typically an incidental finding. You may know someone that has it. They go through it through periods of stress, sickness, when they're fasting. Yes, exactly, Christopher. I just read the chat. Sorry about that. So definitely something benign, but it is, it's a variety of defects and enzymes that affect the conjugation of the bilirubin. Now, there's something called congestive hypothopathy, and we've seen this definitely in the inpatient setting many times. You may have elevated unconjugated bilirubin. It's mostly related to the RA pressure being increased rather than the decreased cardiac output. But it's interesting to know that that would cause some elevation in the intrinsic liver disease category. And then we talked about this last week. Anything can lead to cholestasis within the liver, any forms of hepatitis, cirrhosis, be primary biliary cirrhosis, any infiltrative disease, even pregnancy we mentioned, and TPN. Right? That's always nice to have in that category, and in our differential diagnosis when they're in the intensive care unit. Now, if we're moving forward to extrahepatic cholestasis, same thing, very broad category. So we need to keep in mind cholelithiasis, cholangitis, any malignancy structures. I'm not going to write in them there. We've already reviewed some of this information. Now, what I'd like to do is very briefly go through some scenarios, right? So let me see, Christopher, you were sharing in the chat, so I'm going to pick you. Let's say you have a patient that has an elevated bilirubin, that may or may not have some associated, anemia. All right. Now you have this patient, and I'm telling you, wow, they're coming in with jaundice, but it seems like they're recently sick, or they're stressed over, whatever it is that's happening in their lives. What test would you like to get in this patient?
Oh, sorry. This is like otherwise a healthy patient and has stress in their lives.
That's all. They're 25-year-old. It's the first time you're seeing them in clinic, and they come because their skin is yellow. And for whatever reason, in their annual physical labs, you notice they have, if you were to ever get these, they have an increased bilirubin and may or may not have anemia associated.
I don't know what is the name of the particular test, but it's probable that this patient has Gilbert syndrome, which is basically, which is like stress, hyperbilirubinemia, and after the stress resolves, it will go back to normal. I mean, I will get the direct and indirect bilirubin. The indirect bilirubin will be high. The direct bilirubin will be normal. There's a specific enzyme. I forgot the name. I think it's UDP.
And I think, and it makes sense because
it has a decreased activity during that time.
Yeah, there are many defects in the enzyme activity. When someone has Gilbert's disease, we usually don't get any tests, and that's why you may not remember the name of the enzyme, because it's not commonly something that we do. If they have a history that has a high, pre-test probability, your clinical scenario is pretty clear, you may not get anything. And as a matter of fact, your patient will tell you, yes, I've had this happen before, and it resolves on its own. Now let's say, and let me pick someone that hasn't, maybe Karen, if you are in the call, I think you are paying attention. Let's say your patient now has an increased bilirubin, does have some anemia, but you also notice there's some other, I'm sorry, it should be this way, abnormal labs. What tests would you like to get in this case? Kieran, are you there?
Yeah, hi.
Yeah.
You could look for things like G6PD, looking for cause of anemia, then like Coombs test for like.
I'm going to read it out because my handwriting isn't great. So you have an elevated LDH, you have a low haptoglobin, and you have a high red tick count in someone that's coming in with a high bilirubin level, and you have low hemoglobin as well. What would your
so that looks like I'd be concerned about hemolytic anemia.
Right, exactly.
So you can do like a Coombs test to look for autoimmune. You can do like a peripheral smear. You could do
perfect
G6PD if they haven't had that done, and they've got risk factors.
Perfect. I'm very cheap, so I'm good with the peripheral smear and the Coombs test. I think that's a good start. That's perfect. Now let's say, Karina, let's say your patient has now both elevated bilirubin and you have an elevated AST and ALT. What will you get in this case?
So you want to check for causes of hepatitis in that case. So the viral hepatitis, and then you would also want to check for autoimmune markers for PBC and autoimmune hepatitis. So anti-smooth muscle antibody, anti-mitochondrial antibody. You can do the anti-liver kidney antibody. I think it's LK1. Yeah. And some other viruses can cause hepatitis as well when they're reactivated, but you wouldn't, I don't think, routinely do those. That might be like second line to check for HSV and Sehmbhi and EBV.
That's perfect. And I think that's what Mantej will share now. And in the interest of time, obviously I'm not gonna, and thank you, Fatma. Absolutely agree with what you're saying, sharing in the chat. Now, in this case, you would think of an obstruction. So maybe you would get imaging, and I'm referring to, and what you said, Karina, was perfect. In this case, you would think maybe an obstruction, you would get some imaging. But Mantej, please Go ahead with your presentation. I will stop my share so you have enough time.
Well, thanks. I was enjoying that, but thank you. Okay, so yes, so that was a quick whiz through of jaundice. So the clinic that you work in has like instantaneous lab results. So these are the ones that you have on the day that you see the patient. So you get a total bilirubin of 6, direct bilirubin of 3, ALT of 1,600, AST of about 1,300, and ALK phos of 192. You also check her coagulation, which is normal, and a CBC is also kind of unremarkable. You also managed to get a stat ultrasound abdomen, which shows mild hepatomegaly, a smooth hepatic contour, no bowel dilatation, but they always say that they're unable to track the CBD down to the pancreas. Otherwise, kind of no vascular thrombus, no ascites, normal spleen. It's just an unremarkable scan apart from that hepatomegaly. Then, with the kind of workup of jaundice in mind, you send some hepatitis serologies, and this is what you get. So you have Hep B surface antigen positive, Hep B antigen positive, B surface antibody, B antibody, and B core antibody are all negative. Her hepatitis B viral load is 17 million. HIV, Hep C, a negative. Hepatitis A virus, IgG, is positive. And Hep A and Hep E, IgM, are both negative. So, I mean, surprise, surprise, the patient has hepatitis B. Now, I just wanted to talk a little bit about the hepatitis B serology, because I think it can be kind of confusing. So Hep B surface antigen is a marker, is kind of the marker of current hepatitis B virus infection. Hep B core antigen also is a marker of current Hep B infection, but it's not something that we really test for because it's not really commercially available. But if you did, you probably would see elevation of Hep B core antigen as well. Hep B antigen I'll come back to. Hep B surface antibody implies the presence of immunity, which could either be from previous infection or from vaccination. So for those of us who've had a Hep B vaccine but haven't previously had Hep B, we would all be positive for Hep B surface antibody. But Hep B core antibody means that there has been past infection. And this is because you're only ever exposed to Hep B core antigen if you actually have an infection. The Hep B vaccine really shouldn't give you that unless something's gone wrong. Hep B E antibody, so it's the antibody to E antigen. So I'm just going to ask you guys, and so what does Hep B E antigen mean? If that's positive, what is the meaning of that?
That the patient is infectious, that can transmit Hep B to others.
Yes, so you walked right into my trap, Christopher. Thank you. So that is what we all learned, that Hep B E antigen means that the patient is infectious. So that kind of is true, but it's not strictly a marker of infectivity. It's a marker of early infection. So I know we all learn, I think it's a step 1 mnemonic, that like Hep B E antigen means the patient is infective, and so that they're more infective. That was maybe the case, like, 20 years ago when these things were checked on histological slides. The true marker of Hep B infectivity is the Hep B viral load. So back at a time when we didn't have PCR, people would see Hep B E antigen positivity, and they would see that these patients tend to transmit the virus more effectively. And so the conclusion was drawn kind of reasonably that this means that they're more infectious. But it just so happens that Hep B E antigen usually correlates with Hep B viral load. It's actually the viral load that marks infectivity. So if someone is Hep B E antigen positive and their viral load is 2,000, and someone else is Hep B E antigen negative and their viral load is 20 million, it's kind of intuitive that the person who's got a lot more virus in their blood is going to transmit it more readily than the one who happens to have this random antigen. So yeah, it's not actually a marker of infectivity. It's just earlier phase of infection usually. But the ones I think key ones to remember, so surface antigen means there's current infection. Core antibody means past infection. Surface antibody means usually immunity, but you can't really decide how they acquired it unless you also have a core antibody. So then the next question is for you guys, would you admit this patient? So you're an outpatient, she's got jaundice, her ALT is 1,600, AST is 1,300, otherwise looks well, but she's quite deeply jaundiced. Would you admit this patient?
I guess if she only doesn't tolerate oral intake by her vomiting, nausea, or if she has signs of acute liver failure, I mean, also mental status or high INR, it would be indication for admission. Otherwise, there is no need to.
Hep can rapidly decompensate, and you don't know what her LFTs are going to do and like whether this will progress to liver failure. So I think until you've trended something, I would send her to the ER.
Okay. Yeah, they're both kind of reasonable thoughts, and I suppose it would be reasonable to be kind of cautious and arrange for at least a repeat measurement the next day. Now, so it's a bit unfair because the context of this patient was a little bit different, but and I will come down to it, but we did not admit this patient. We decided that she could be managed and monitored in a close kind of outpatient setting with strict kind of safety protocols. And I'll come back to that in a bit. You repeat some labs 5 days later. She's come back into clinic. Her bilirubin is now 4.6, down from 6. The total bilirubin, the direct bilis down is 2.1 from 3. ALT and AST and ALP are all kind of trending down. The INR is still normal at 1.1. The viral load is almost halved in 5 days, which is quite a rapid reduction. Her surface antigen is still positive. Her Hep B E antigen is now negative. Hep B surface antibody remains negative. Her Hep B E antibody is positive, and the core antibody is still negative. So just based on what we discussed so far, what does this kind of mean is happening to the patient?
This is like acute phase of hepatitis. You said that all the symptoms have been for the past 2 weeks, right?
Yeah, I mean, 2 weeks of jaundice, a couple of months of fatigue, nausea.
A couple of months, but less than 6 months, right?
Yes, less than 6 months. So yeah, it's so this picture kind of suggests the patient is clearing the virus. So the fact that she's now seroconverted E antigen to E antibody means that she's kind of passing that really high viral load acute phase of it. But she still has active Hep B, and as evidenced by the surface antigen, and the fact that she doesn't yet have any antibodies to the virus. So she still has active virus replicating and circulating. But it looks like she's clearing it. The point about the liver function tests, so is kind of reassuring to see they're downtrending. The fact that there was an elevation at all means that there's been an immune reaction to the virus. Because if what actually generates the hepatitis is the immune reaction to it and not the virus itself. So the liver enzymes here and the bilirubin suggest that liver inflammation is reducing, so that the intensity of the hepatitis is coming down. So she's kind of on the path to recovery. So I just wanted to talk a little bit about hepatitis B modes of acquisition, particularly in light of for this patient. So as you probably know, you can get Hep B vertically. Otherwise, you can get it vertical, as in sort of from your parents. You can get it bloodborne, which could be either from contaminated needles, transfusions, or nosocomial infections. So, for example, from needle stick injuries or contaminated instruments. You can get it sexually. And you can get it after a transplant if your donor has hepatitis B. In this patient's case, can anyone think of the kind of major risk factor?
I think we didn't ask sexual history, and yeah, transfusions, I don't remember if it was asked either.
Yeah, so she didn't have transfusions. She hadn't had sex for 5 years, more than 5 years. She had that operation a few months beforehand. And now we were a bit unsure if this is, it's a bit of a thorny question. Is that how she acquired Hep B? Because that shouldn't really happen in this day and age. But that was the only real risk factor we could identify for our patient having acquired Hep B. I'm just going to whiz through briefly sort of Hep B. So in the acute phase, you have an initial infection with a 1 to 4 month prodrome. Most of these patients, actually, the majority have a completely subclinical hepatitis. So you may people may not even know that they've acquired Hep B, and they're actually, this is the acute phase of infection. 30% will have a nicteric hepatitis, like our patient with jaundice. And like we were saying earlier, so the risk of fulminant liver failure is pretty small. It's only 0.1 to 0.5%. So for that reason, we felt it was okay to manage this patient as an outpatient. Evidence of acute liver failure would be coagulopathy, as we were saying. So we were reassured by the normal INR, any encephalopathy, or if there's kind of very extreme jaundice, like sort of above 10 or so, but that's not really strictly defined. And the other thing is, interestingly, in these patients, there's usually no evidence of active Hep B replication, so you don't usually have much of a viral load, suggesting that the reason for the people who have fulminant liver failure just have an over-exaggerated immune response that destroys the liver. It's not actually the virus itself, it's just the extreme immune reaction that causes the problem. So then what actually happens after the acute phase? So it kind of depends on when you're going through it. For people who have infection when they're born, only 10% actually clear the virus, and the immune system just recognizes it as probably part of them, incorrectly recognizes it as part of them, and they just tend to progress to chronic Hep B. In childhood, 50 to 80% clear the virus, but in adulthood, more than 95% of patients clear the virus and don't get chronic Hep B. So that looks like the path this patient was on, given her blood results after 5 days. We discussed this briefly. So indications to admit are usually if there's very deep jaundice, if there's coagulopathy with an INR of 1 with 1.5, if there's encephalopathy, and then otherwise other kind of indications if the patient has lots of comorbidities or is very old or has poor social support. Our patient was fairly young and healthy despite this kind of current event. So we thought she could be safely managed as an outpatient. Quick question again, would you treat acute Hep B with antivirals?
Maybe not yet, because what if the patient is able to clear the virus for herself? So I think unless like the patient may be like acutely decompensated or something, and even in that sense, you will manage it like you will manage the decompensation rather than give viral antivirals. So I think you will give it for a chronic viral hepatitis type of thing, but not for the acute setting, because if the patient is able to clear the virus for herself, then the antivirals won't do anything. It will be just wasted resources.
There's that really complex algorithm about whether or not they have Hep E antibody, and then what the viral load is, and what their LFTs are doing to determine if you treat or not.
Yeah, I think you're alluding maybe to more the chronic
yeah, for chronic Hep B.
Yeah, in the acute phase, actually the evidence is a bit unclear about whether you should treat or not. The only study was on lamivudine, which is a much older antiviral than the ones that are used now, and that showed no benefit versus placebo in terms of mortality, in terms of conversion to chronic hepatitis B. But newer antivirals like tenofovir, TDF or TAF, or entecavir, which is the ones that are used now, don't really have an evidence basis yet. So we're actually going to be doing a project on this. So, watch out for that. The thing with antivirals is some people choose to treat it if the patient's going to have a liver transplant, if they do have acute liver failure, because you don't want the virus to reinfect the new liver. But that's the only kind of really well-established indication, but nothing else, everything else is a bit uncertain. So you can just watch the patient. So chronic Hep B, I was going to ask you what it is, but I'm just giving it away. So if you have surface antigen for more than 6 months, okay, that's what makes Hep B chronic. So you have up to 6 months to clear the virus before you can call someone chronic Hep B. And remember, this only happens with 5% of adults in adulthood-acquired infection. And then, yeah, as Karina was alluding to, there is this complex algorithm, which I think probably isn't worth going into too much, about like when you do or don't treat these patients. Generally speaking, to remember it easily, you can say that if there is hepatitis with chronic Hep B, you start treatment. And hepatitis is defined by the presence, I don't know if you can see my cursor here, but it's defined by the presence of a high ALT. So if you have a patient with chronic Hep B who has high ALT, obviously in the absence of any other sort of reason for that, then you should give them antiviral treatment. Otherwise, if the ALT is normal, it's a bit more complicated, but you generally speaking don't necessarily need to give treatment. Of course, I mean, if I had 70 million copies of Hep B viral DNA per mil integrating in and out of my genome all the time, in and out of my p53 gene, everything else, I might want some antiviral treatment. So I think there's like some discussion about this. But hepatitis is the only kind of definite indication to treat. Just some notes here at the bottom. So E antigen status usually tracks viral load. So you tend to lose E antigen as your viral load drops. Again, fitting in with that kind of, it's an early marker. And yeah, and you can always reactivate so E antigen negative infection can reactivate to any of the others if someone is immunosuppressed, for example. So that's when you as you probably know, when you give immunosuppression, if you want to give someone rituximab, you always have to check for Hep B serology beforehand to make sure they've not been previously infected with the virus, because even if they've had it in the past, although it's now cleared, they usually have some residual virus that can reactivate and kill them if you immunosuppress them with rituximab or other agents. So it's important, it's mandatory, I think, to check that before you give those drugs. And the last word on management. So it is complicated, the viral management. So tenofovir, TDF, tenofovir disoproxyl fumarate, or tenofovir alafenamide, two kind of different drugs. So they're described separately, even though they're just tenofovir. So TDF or TAF or entecavir are the ones that are used at the moment. But it's complicated, so usually only the hepatitis. And then general management, which is more sort of for kind of internal medicine purposes, is going to be screening for other viral disease, vaccinating them against hepatitis A, for example, avoiding alcohol, and other liver risk factors, and of course liver fibrosis measurement and Hep C screening for those patients who need it. We discussed this a bit. How did our patient acquire her infection? So, likely it was, we think it was probably the operation that she had that was the only identifiable risk factor, which is a very difficult thing to raise for the patient. She had it done in an outside hospital. So we actually just asked her to check with infection control at that hospital, just to say that she had an operation there some months ago. She now has Hep B acutely. So they may want to run some checks and just do an investigation into how that actually happened, because that was the only risk factor we could identify. So just to wrap up, when I feed you lemons, when life gives you, jaundice after a surgery, make sure you screen for hepatitis, because you may have picked it up somewhere. Any questions?
There are a few in the chat, but I'll screen some of them. Okay, all right. So how often, Nick is asking, should we be trending labs during the acute infection and when monitoring for transition to the chronic phase?
So it does depend on the patient. So if there is, this patient was actually having them done every 3 to 5 days, because we were managing a kind of close outpatient, and we wanted to be. It depends on the phase. So if it's the first time you've checked these results, you probably want to do them within 2 to 3 days if you decided they're safe to manage as an outpatient. And then once you're sure that the INR is not going up, and obviously the patient is remaining clinically okay and not encephalopathic, and you have evidence that liver enzymes are starting to downtrend, you can space them out to weekly, or even even less than that. So it depends on the phase. And for transition to chronic infection, so chronic infection is defined as the presence of surface antigen for more than 6 months. So whatever happens, you have to wait 6 months to recheck a surface antigen after you first detect the infection to say the patient has chronic Hep B.
Karen was suggesting this could be late onset vertical transmission.
Yes, that was a really interesting topic. It could be, and it is actually very difficult to truly differentiate acute Hep B from reactivation of perinatal infection. Definitely could be, but the reason we thought that's unlikely, oh yeah, no, that was the reason. So she had been pregnant in the 90s and in early 2000, and so then obviously you check Hep B status during pregnancy. So the patient didn't know that she was definitely negative, but had not been told at any point in her life that she had Hep B. So we kind of used that as just as to mean that she didn't have Hep B in 2000 or 2005. So.
And Fatma wants to know if you
also she has.
Sorry.
I meant like she had hepatitis core antibodies negative, so I don't think it's chronic infection for her. Usually chronic infection would have positive core antibodies or for the reactivation as well.
Where was the patient from? Did you get that?
The patient was from the US, from the Northeast US, I think New Jersey, so where she was.
How old is she?
59.
Okay, because so understand the vaccine itself has just been developed in the 90s, 80s, 90s. So remember back in the 80s, most healthcare workers, it wasn't really HIV, it was hepatitis B that people were getting infected with. And then vaccine happened, and then the pediatric schedule included hepatitis B series, like really in the late 90s, early 2000s. Like my generation didn't get hepatitis B vaccination when we were growing up, but most kids like now in their 20s and 30s, most of them, if they grew up in the US, usually have gotten the hepatitis B vaccine in their series before. And that was part of the pediatric schedule. My thing with this case is I think there needs to be more digging regarding like any needles, because even acupuncture, there's a lot of people going out to other places, tattoos, was there injections for pain, you really have to be careful with needles anywhere, because you really then have to say that this place is OSHA and is really being careful with their needles. Most people, you guys know that hepatitis B, hepatitis C, HIV, hepatitis B, the rules of threes is 30% is hepatitis B, 3% is hepatitis C, 0.3% is HIV in terms of transmission. So whenever someone talks to me about needle sticks, I'm always more concerned about Hep C than even HIV, because you can get PEP. Hepatitis B, we don't get worried as much because all of us need to be vaccinated and we show immunity. In terms of pregnancy, that's a good catch, but I also agree with Nora, like it would have been a core antibody there if you would have thought that this was like a more longer duration. And then the only other teaching point from the hepatitis B versus hepatitis C is understand that hepatitis B also is at higher risk for hepatocellular carcinoma and not necessarily Hep C. So this is the one that you really regularly need to get an ultrasound or CT, depending on, and I've asked, other people, like when would you get an ultrasound versus a CAT scan? Depends on habitus, but also I'm very old school. I still trend the alpha-fetoprotein. So if the alpha-fetoprotein is running high or starts peaking up, then I may decide to do a CAT scan versus just a regular ultrasound. But this is the one that you really have to be on top of your screening for hepatocellular carcinoma for Hep B as opposed to Hep C. And those are the things I just wanted to kind of catch. And that's it. It's 5:05.
Thank you, Dr. Mantej, do you want to run through some of the questions? The majority is thanking you for a wonderful presentation. And I think Fatma just had a question about testing the partner. Did that ever happen?
Yes, the patient was kind of irreconcilably estranged from her partner. She hadn't seen him for more than 5 years. So we told her that she should contact him, but she really was against that idea. Yeah.
Thank you so much, Mantej. I just want to say something. Noor was advocating for hepatitis C screening, and I would go with hepatitis B screen as it is preventable. We can prevent it, like, I don't know how much percent, but I'm sure very high percent with just a vaccine. And it easily can be screened, especially that we are in New York, we have a big population, like African immigrant and other immigrants from all over the world, that they might not get the vaccine, as Dr. Uzari was saying. It was introduced in the US 1981, I guess. So we have a big population who might not receive the vaccine before. And I want to add also one thing, that there is the permanent makeup. I was surprised that it's like a permanent tattoo. And it uses needles that sometimes can be a source for the infection as well.
Yeah, definitely. Needles are definitely a big part of it. And this patient kind of absolutely denied any needles, any acupuncture, anything like that at all. So we had to go on that. But yeah, definitely a major risk factor.
I don't see any more questions in the chat. It's 5:07. You kept our audience waiting for the final. Thank you so much, Mantej. It was an excellent presentation. See you all.
Thanks, everyone. Bye.